Hello, everybody. Everybody can hear me? We're good. Mics are on. We good? Yes? Okay. I'm like, I need you guys to tell me if we're good or not. All right, guys, welcome to Cozy Talks Live. I have two very special guests here with me this evening. I have Glenn Runyon, who is an ambassador for Integrum. He is a high school teacher and football coach, which makes him pretty much a saint, in my opinion. And we have the one, the only Dr. Jonathan Forsberg, who doesn't know that I've been after getting him on the show for almost 3 years now. So yay, cross that one off the bucket list. So just wanted to say a very big, warm welcome to my two guests this evening, and a huge thank you to Integrum for sponsoring this show this evening, and also to Memorial Sloan Kettering Cancer Center for letting me borrow Dr. Forsberg. So we're just going to say a quick, we've got a lot of people jumping on board and a lot of both of your fans. We've got G.I. Jane in Arizona. We got Scott coming in from West Virginia. Dave, good to see you. I knew you were going to be here this evening. We got Robert, Susan with Marshall. You know that Marshall's going to be sitting there waiting for us. We've got Martin on board with water. Guys, if you are new to the show, you need to let me know who you are, where you're from, and more importantly, what is in your drink. So everybody, let's start the evening right. We're going to raise whatever you got there. You're almost done, Glenn. You need to get a refill there. All right. Cheers to this evening, guys. So for those of you joining me for the first time, welcome. My name is Cozy Belloso. I'm a physical therapist here in what is now becoming hot, sticky Tampa, Florida again. I've been a PT for over 23 years, and my passion is working with the amputee and limb loss community. But we're going to hear more from these two. I can never get this right. These two gentlemen this evening. We're going to hear a little bit from Dr. Jonathan Forsberg. Like I said, he's on loan to us from Memorial Sloan Kettering Cancer Center, orthopedic surgeon, director of orthopedic research, actually, and he'll be telling us about his work. And then Glenn is going to be telling us his story with OPRA and osseointegration. So we are going to jump right into it, guys. The purpose of tonight's show, and I always kind of like to start off with, this is what you can expect from the show tonight. We're going to be talking about osseointegration, osseo-anchored, bone-anchored prostheses. There's 40 million words for it nowadays, with a focus on the OPRA system made by Integrum. And specifically tonight, we're going to be talking about the aperture site, the exit site. So where the abutment exits the leg, because there's always a lot of questions about what does the skin look like? Is it a wound site? How do you take care of it? Infection, all these kind of questions that we get that we are going to be covering tonight. So I'm going to go ahead and just shush for a moment, and I'm going to let my guests introduce themselves. So Glenn, you're in the hot seat. So I'm going to have you tell us a little bit about yourself. Not too much, because we're going to be going more into your story a little bit later on.
Well, first, I'm so excited to be in the hot seat. All these years listening to this show, and I finally get to be here. So thank you so much for inviting me and for Integrum for giving me this opportunity to be here. But as Cozy mentioned, I'm a high school teacher. I teach outside of Wilmington, Delaware, and I coach football, among other things. But and I've been an OI patient since December of 2019, and Dr. Forsberg was my surgeon.
There we go. Go ahead, Doc.
Well, that's great, Glenn. It's so good to see you again. I never get to see you since I moved up to New York. But I'm Jonathan Forsberg, orthopedic surgeon and orthopedic oncologist, really, at Memorial Sloan Kettering Cancer Center. I've shifted my practice to mainly taking care of cancer patients. But I'm proud to say we finally published the results of the transfemoral OPRA study and the transhumeral OPRA study, which was an early feasibility study. Both of those were funded by the DOD. So I'll talk about some of those results today. But I'm very excited to be on the talk, Cozy. Thank you.
No, and guys, the studies that he is referencing, it's like my nerd flag is going really high right now with this. This is a lot of years of research that went into putting the study out, and it came out quite literally a few days ago, if I'm not mistaken, not too long ago. So it is literally hot off the press, and we're going to get some details on that. We have a lot of people on board, and guys, if I did not say my usual hello to you, please forgive me. So many of you here, and it was interesting in the pre-interview. I was with Dr. Forsberg, I was saying, you know, oncology amputees represent less than technically 2% of the amputee population. But for whatever reason, we do have a very high number of osteosarcoma survivors here on this show, including the one sitting next to me right now, who's going to be telling, oh, he's got the shirt on. I just noticed that now. All right. So guys, these are the two men you're going to want to ask a lot of questions. But before we do, y'all know I love my giveaways, and my sponsors are so incredibly generous. So those of you who have been participating in the giveaway prior to the show, thank you very much, because this is how we show our sponsors support as well. So I'm putting out a QR code right there. Okay, and this is a link to Glenn's video story, which again, for me, I need to move out of the story there. For you guys, it's just wonderful to hear someone tell their own story. Every story is completely different. So to be in this giveaway, you still have time because I'm going to announce the winner at the end of the show. Click on this QR code, like the video, and subscribe to Integrum's YouTube channel. I was really pouring through it this week, and they have some really amazing stories with their ambassadors, some of which you've already seen on the show. So I'm going to leave this up for just another couple of minutes. And we're just going to go ahead and also get started on the show. So I always like to kind of review what is OI. Many of you have watched the show before, but for those of you who are new, perhaps some of you who are actually, I see already in the chat section, many of you who have had stage 1 done and are waiting stage 2. So we're just going to give you the simple overview. So when we're talking about osseointegration, guys, we're talking about the body's ability of the bone to fuse with metal. And Dr. Forsberg, you got to keep me in line here to make sure that I'm saying everything correctly.
You're doing a great job so far.
Yeah. Okay. And this concept was actually kind of pioneered in the 1960s by a gentleman by the name of Dr. Brandemark, Professor Brandemark, excuse me, when he was developing what became the modern dental implant. So if any of you have a dental implant, that technology started in the 1960s. So Professor Brandemark's son, also called Dr. Brandemark, he took this a step further. And in 1990, he created the implant and implanted the first transfemoral amputee using this osseointegration technology so that she could then use a prosthesis without having to use a socket. So that's just the very simplified way of describing it. And as I said earlier in the show, it's called osseointegration, osseo-anchored, bone-anchored prosthesis. You're going to hear a lot of this terminology. So Dr. Forsberg, what is it? How are your patients addressing this? How are they calling it? What's the popular term?
Everybody calls it osseointegration. I mean, I think that term's here to stay. You know, technically, it's the bone that grows onto and into the interstices of the titanium oxide layer. But you know, everybody calls it osseointegration, or osseo for short. You know.
Osseo, yeah. And guys, I'm going to throw up these 2 slides. I love these slides because it shows on a microscopic level. It looks like something out of that movie Aliens coming in there. But just to show just how closely this metal fuses to the bone. It's really kind of fascinating. All right. So let me get back to the screen. Guys, you guys know me that I am not a tech person. So me navigating these screens, here we go. All right. So when we're talking about osseointegration, since its inception in 1990, there have been about 17 different types of osseointegration that have been played around with. Obviously, not everything came to market. But the 3 principal methods of OI that we're seeing globally, we refer to them on the show as the screw fit method, which is the OPRA's Integrum method, the press fit method, and the compress fit. And then Dr. Forsberg is going to correct my vocabulary on this one, and he's going to clarify a couple of things.
I'm happy to do that, Kosi. The term press fit gets a lot of play, and you know the term press fit came around when surgeons were trying to get a femoral stem to heal or to be fixed to the proximal femur in hip replacements. And in that time, there were 2 schools of thought. One, you could just cement the hip stem in place, and the other one was a press fit, where you would introduce the implant in such a way that it would engage the cortex, the thick outer covering of the bone, and that's where press fit came from. Okay. So I would tell you that you know, all implants are press fit unless you're dealing with a compress. That the compress is different. We could spend hours talking about the compress.
Yes.
But, you know, to do osseointegration correctly, the surgeon has to interdigitate the implant, however it's shaped, with the cortex of the bone, whether it's a threaded device or a long stem device or a short stem device. They all engage the cortex, so they're all sort of press fit.
Okay. Now, when it comes to, there are differences between the three methods, and one of the primary methods that they're different is how the soft tissue is handled, and that's going to be the topic of our discussion tonight, meaning how it looks like when it exits the body. And guys, just because there's so much information we're wanting to cover tonight, but I don't want you to miss out on anything, the QR code I just posted above Glenn's head is the show that I did where we went into more depth about the different types of OI and the pros and cons of each and the differences between them all. So if you guys want to do a quick scan of that and save that one for later. But in the meantime, let's dive a little bit more. Glenn, you've been a little too quiet, and that's just not okay on this show. So we want to hear from you. And I think you have a couple of fans on the show. I think a couple of your students are here.
Well, I may have offered bonus points for the students to log in this evening and to say hi. So if you see me taking notes, I'm writing down the students that actually are here, because every little bonus point helps, as you know.
Absolutely. I'm seeing a hi, Mr. Runyon. So I'm
Yes,
assuming
right.
that is one of the students right there. Well, congratulations. You have some really amazing students who are taking the time. So but tell us.
Mr. Runyon or Coach Runyon work. So either one of those would be acceptable. So,
So tell us a little bit about life before amputation.
Things were going smooth. Like, things were going great. And I would say that the activities I did, like, I'm a high school teacher. I mentioned that. I didn't neglect to say that I'm a U.S. history teacher and an AP government teacher. So, and then I've been coaching football. I work at a school called Concord High School outside of Wilmington. I've been there for 19 years now. And, life was smooth before amputation. Things were great. Everything was going well. And then if you watch my video, you'll see that I thought all this stuff going on with my leg had to do with, I got hit on the sideline, and we managed, there's this program called Huddle that all these schools use. And I was able to draw that thing out from 10 years ago and put that little clip on there where I actually got run over, and I kept getting all this pain. And I just assumed it was that. But as you and I were talking, it was probably a good thing, because I kept going, trying to get this fixed. And I didn't ignore that something was happening on my way to, and here's a shout out to you and all the other PTs. I'm convinced the PT saved my life, because I was like, there's this bump behind my leg. And then she's like, okay. And she sent me, and then she's like, and they kept saying, it's a Baker cyst. And the PT is going, I don't think that's a Baker cyst. And then to her credit, she kept pushing my doctor, who sent me to more and more tests. So, but I was, like, things that I like to do. I like to be outdoors. I used to run a Boy Scout summer camp. So that was what I did for the summer for 20 years. I was in a camp in the Adirondacks. So we were surrounded by 6 million acres. That was what I used to do for fun in the summer, was I would go up there and go camping for 6 weeks in the woods. I've always been outdoorsy. We have a cabin in the woods now in PA. We ride four-wheelers, side-by-sides. We have a boat, jet ski. And I would be happy to say that I'm able to do all those things now with OI, which when I went to Dr. Forsberg, one of my biggest gripes was, like, my quality of life just wasn't going great. I was frustrated. I'm that typical, when you hear all the OI stories, I'm that guy. Like, nothing worked well for me. When I would go to PT and they're like, drive your hip. I would drive my hip and my leg would come right out of my socket. And then I would lose all confidence in my socket. So then I never really walked well. It was uncomfortable. I've told these stories all the time. I'm out riding my four-wheeler. We're in the middle of the woods and my leg falls off. So now I'm on a trail on a hill trying to get my leg on. I just felt like the frustration level was there. And then, thankfully my prosthetist is the one that said, hey, they're doing this operation now down at Hopkins. Because I learned about OI as soon as I, talk about being prepared. When I knew that I was diagnosed with sarcoma, and I knew that I was going to get my amputation, is I went online and I wanted to look up everything I could. And I found Integrum, but it was only in Sweden then. And they had, I didn't know they were doing it at Walter Reed. And I'm like, this looks great. Why don't we just do this? And my surgeon's like, yeah, well, we don't do that. And I can say this thing my surgeon was most concerned with was infection. And she's like, oh, the infection, which it's a real fear. There's no doubt. And Dr. Forsberg, I'm sure we'll speak to that. And then I got down to Johns Hopkins. I met Dr. Forsberg, and it's a little overwhelming when you go there, because like 18 people. Okay, it's not that many, but it feels like there's 18 people who come into the room. They all introduce yourself, and you're going, I hope there's not a quiz later, because I would have failed. But
it was an intervention, Glenn.
It was an intervention. But you remember the PT. You probably remember the PT. Yeah,
I would say that I've never been in intervention, but I assume that's how it feels like on the other end. But I will say the quote that I don't know if Dr. Forsberg still uses, but I think this sat with me the best. And he was like, you're going to exchange one set of problems for another when you go to OI. But I had so many issues with the socket. I was ready for anything, to my mind, had to be better. And then when Dr. Forsberg says, you're a candidate, the only thing, he's like, do you have any questions? My only question was, how soon can we do this? I am ready to go right now. Since 2015, I've been ready for this. And then, and thanks to you, because that was when you had Kurt and Brian on.
Yes. It was right before they got the approval for FDA.
They were so new at Hopkins. When I called, the lady on the phone didn't know what osseointegration was. And I was trying to say, I saw this thing, and then, but then I reached out to you, and thank you very much for that. I mean, you got me on the road, and then Kurt made some calls, and magically I got a call, and I got into the clinic, and then I think I was in the clinic in October, and my surgery was in December. So it was
with one of the top surgeons in the U.S. doing this procedure. So someone was definitely.
I wouldn't go that far.
I've already said it several times, so you're stuck there. You're stuck there. So yeah, and we have actually, we said, so Kim is saying she's a synovial sarcoma cancer survivor. Guys, those of you who are cancer survivors, if you don't mind, go ahead and put it in the comments section. I myself am a cancer survivor, so it's always nice just to have that crowd around and just to give a shout out to the folks that have survived. We've got Carol on board as well. We've got Donnie, Christy, and Victor coming on board as well. And guys, I have everybody from Facebook, YouTube, and Instagram tuning in. So thank you guys again ahead of time for being here this evening. So we heard Glenn talk about his time at Johns Hopkins, but I talked about Memorial Sloan Kettering. So I think, Dr. Forsberg, I think you've got to kind of help straighten out your history just a little bit for folks right now. So it's your turn.
Thank you, Cozy. Well, Cozy was going to ask me, how did I get interested in OI? And I was in the military. I actually retired from the Navy in 2022 after 32 years. And a large chunk of that time was spent at Walter Reed taking care of combat casualties. And after the wars ended, we still had, just under 2,000 major limb amputees, and they still had problems with their socket, just like Glenn described, and they were still unhappy. And this is a young, previously healthy patient population. So I was actually in Sweden doing some graduate work for my PhD, and I knew of Rickard, and I knew of his inroads. He was trying to make inroads with the DoD, and it was challenging. There were political movements that were going on. The DoD had invested millions of dollars into a U.S. group that was developing their own kind of implant. But I met with Rickard, and he was kind enough to teach me the surgical technique. So I would either fly or take the train from Stockholm to Göteborg to where Rickard was, and he taught me the surgical technique. And when they were close to getting humanitarian use approval from the FDA, I said, we should really write a DoD grant. Actually, we wrote 2 grants, and that was about, I want to say we started writing in 2012, 2013 timeframe, and they were funded in 2014, and we started enrolling in 2015. So thank goodness they're over. Doing a clinical trial with 2 years of follow-up is like raising a child.
Yeah.
Now the child's released out in the world, and thank goodness. So I retired from the military. I went to work at Johns Hopkins. I actually had an appointment at Johns Hopkins as an active duty orthopedic surgeon, which is a fairly unique arrangement. And then once I retired, I had every intention of just joining the Hopkins practice, but I was offered a senior faculty position at Memorial Sloan Kettering, and that is very difficult to turn down, Cozy, I gotta tell you. So I'm up here in New York City. I love it. I love what I do. I love my partners. I love the institution. It's just wonderful.
Well, and I've been hearing nonstop from my colleagues at Johns Hopkins and how much they miss you. So, I knew it. Memorial Sloan Kettering, speaks for itself. We've got Jim on board. He's a stage 4 colon cancer survivor from 2014. Congratulations to you, Jim. We've got Carol on board. She's also a cancer survivor. My girl Mary, right there, cancer survivor, Ewing sarcoma and osteosarcoma. Good heavens, Mary. Let's see. Pat is my 2-time cancer survivor, melanoma and prostate, but amputation due to blood clots. So. Lots of folks here this evening with their different colored ribbons this evening. So what drew you in particular to OPRA? Because you are obviously well-versed in the different forms of OI. What is it about OPRA that you like, don't like? Tell us a little bit about the comparisons that you think.
Well, it really rose to the top of the scientific community gradually. And the Integrum and Rickard did the right thing. They developed a surgical technique that worked, and they didn't just let anybody do it. They trained the surgeons. They make sure the surgeons knew how to treat the soft tissues and he taught us all that the soft tissue is probably the most important part of an osseointegration operation. And, at that time, we thought we knew more than Rickard. This may come as a shock, but but some orthopedic surgeons are fairly self-centered, fairly arrogant, think they're smarter than everybody else. I know that sounds crazy.
That's funny. That's what they say about PTs. You're in good company.
So we started developing the compress, and we also had the long stemmed implants on our radar. We traveled to Sydney. We learned the long stem technique, which was just it's just a long stem. Orthopedic surgeons have been putting in long stems forever.
Yeah.
And so we were familiar with all surgical techniques, but OPRA really did have the science, the good science, the good basic science, the animal work, the translational science, and finally the prospective clinical studies that led to its FDA approval. And as soon as it got FDA approval, I knew we were in the right group of people.
Absolutely. And guys, just to clarify, right now, currently in the United States, the only FDA approved method of osseointegration is the OPRA Implant System by Integrum, and it is only currently approved for above the knee amputees. Many of you here will say, well, I've seen the press fit method and I've seen it on a below the knee or on a transhumeral above elbow. These are being done in the United States through, and let me see if I get these because I always get these acronyms wrong, investigational device exemption or human compassionate use. And please forgive me, FDA, if I didn't get that terminology correct.
Or straight custom.
Thank you. Thank you. So it is done on different levels of the body. So we've seen, above the knee, below the knee, transhumeral, below elbow, and we have thumbs.
Yep, we have a thumb. We just did a thumb over
not
the
too
summer.
long ago. Yeah, so it's quite applicable throughout the whole body. So tonight we are going to be focusing on transfemoral because that's what, obviously is the most used right now in the United States. So we're just going to kind of go over probably another one of the bigger differences between OPRA system and some of the other systems is that it does require a two-part procedure at this time. So the stage one, let me get my, I have pictures today, guys. I have pictures. All right. So in stage one, the surgeon is going to implant the implant into the femur right there. And then they close the skin completely. Okay. So for all intents and purposes from the outside, it just looks like the person had a revision. Okay. So they close up shop, send the patient home. And for the next 3 to 6 months, the patient is healing. And on the inside, we're just allowing the bone to fuse with the metal. During that time, and it's usually around the 6-week mark, once the surgeon gives the blessing, the patient can actually go back to using a traditional socket, which I think, Glenn, that was the case for you, correct?
Yes, it was. And this is where having a good relationship with your prosthetist was key. My prosthetist couldn't have been any more accommodating and interested in the new technology. Actually, he's the one that told me that, they were doing it at Hopkins. Mm-hmm. And I was like, I want to be better. And people were like, well, it wasn't too long, but it worked out. I could remember my timeline. My first surgery was in December 2019. Well, the whole world ended in March 2020, which is right before my second surgery was supposed to happen. So I'm very happy I got back into that leg. It may not have been the best socket in the world, but you're a little more comfortable, at least on a limb. And then I didn't end up having my second surgery until August when they started opening the world back up for surgeries. Mm-hmm.
And Dr. Forsberg, you've mentioned in our pre-interview that you have some patients that because of life, they may not be able to come back right away for that second stage procedure. So having this option to be able to use a traditional socket to get from point A to point B in the meantime is helpful.
That's right. And I just treated a patient who had a transtibial osseointegration done by another surgeon that loosened, unfortunately. So I reimplanted him. And then he went back into a socket, and we're going to do stage 2 coming up here in the next couple of weeks.
Okay. Donnie is saying, y'all spoke about quality of life post-amputation. I went to school after amputation to lean to work, build Harleys with a focus on modifications to help people who want to ride again. So shifters, throttles, ECT. I'm interested to see how OI can help people I work with. And Donnie, you are giving us a great lead-in to the study that we're going to get to in just a moment that Dr. Forsberg just published. But before we do, so the time frame between stage 1 and stage 2 can vary, right? The ballpark figure is anywhere between 3 to 6 months. And certainly in the 5 years since it became FDA approved in the United States, we've noticed that time frame has shrunk a little bit. When do you tell a patient, okay, you're ready for stage 2, let's go?
Well, we did the study based on the Swedish data. And in Sweden, Rickard waited 6 months in between stage 1 and stage 2. And when we wrote the protocols, and I can remember his conference room in Göteborg, I looked at that number and I said to him, no American is going to want to wait 6 months in between stage 1 and stage 2. So we have to do something else. Pick a number. Do you want it to be 6 weeks or 3 months or whatever? And he said, let's do 3 months. So we did. And it turned out to be perfectly sufficient. So almost every patient without fail, when I go back in stage 2 and it's at least 3 months, that bone graft is healed and the bone is healed to the implant. Now, cancer patients are a little bit different.
Sure.
And I won't bore the audience with how long it takes bone graft to heal in somebody on chemotherapy, but it takes a lot longer. So
yes.
In those situations, we tend not to choose the OPRA implant system in favor for other systems that may offer rigid stability up front. Chemotherapy or no chemotherapy.
Absolutely. And then, all right, let me see if I can get back to the picture real quick, folks. All right, so once they go stage 1, everything is all nice and healed. Then we move on to the stage 2 procedure. And this is where the real artistry, I think, comes into play. The surgeon will attach the abutment, so this part right here, into the fixture and then create the opening, the aperture, the exit site. So this is where it exits the human body. So this is where the fun really begins. So for those first few weeks after that surgery, that limb has to be protected at all costs. And I'm sorry I don't have a picture for you guys, but there's a fun little hockey puck looking situation that goes on the end of this to protect. Oh, wait, Glenn, do you have it? Seriously?
Yes, I do.
You are
nice. Look at that.
Rock star.
I brought my visual aids.
Glenn for the win.
See that? I didn't know what to do with it. And I was like, what do I do with it? That's Forsberg was like, I don't know. So I threw it in a box in the shelf and look at that. Here it is.
That's what it looks like. So basically that is sitting on the end to protect that site. And as Dr. Forsberg is going to explain much more beautifully than I ever can, the skin is basically tucked in to that implant to really touch this. So the whole point of the healing process afterwards is to make sure that there is no movement, no shearing, nothing to that skin so that it can really stick nicely to that implant. So I'm going to let you talk a little bit more about it, Dr. Forsberg.
Yeah, happy to do it. The one of the purposes of waiting 3 months is to allow the bone graft, which is backfill, is that the fixture is pretty wide and the ultimate abutment is going to be fairly narrow. It's about 12 millimeters or so. So you backfill with bone graft, let it heal. And turns out bone's a really nice substrate for a skin graft to grow onto. The skin graft will heal to the bone, it'll become sturdy. And if it does heal to the bone, there will be no relative motion at the skin implant interface. You're going to show us that in a second. I know. Yes. I can't wait to see that.
You want me to grab that picture?
Awesome.
Let me grab
it. Yeah, let's see it.
An awesome picture.
And there you go. So you can see the outline of the distal femur there.
Right here.
And the skin is adherent to the distal femur, and all the soft tissue is mobilizing around it. But there's really no motion.
Here's another guy.
Yeah, that's a great shot right there.
Right?
Yep.
Yeah. So that's a really nice picture right there of that.
Yep.
How that works.
I agree. And the only reason that works is because the implant, which is a threaded press fit implant, the OPRA, is countersunk into the bone, and the skin graft adheres to the end of the bone, so there's no relative motion.
Got it. Let's see. Jenny says she still has her hockey puck, and apparently Dave does as well. So it's part of the cool kids club. You have the hockey puck.
Only the cool kids get the hockey puck.
What do you do with it? Because when patients say, what am I supposed to do with it? I tell the patients exactly what I told you, Glenn. I don't know, but put it in a drawer.
It's a conversation piece. You know, I don't know.
Paperweight.
So Stephen is asking, how much length must be in the femur to get osseointegration? And also, does the weight of someone bear any factor?
Yes. So for the OPRA, you need about, let's say 92 millimeters, maybe 95 millimeters, which is not a lot. You know,
it's actually the shortest implant available on the market. Am I correct in saying that?
On the market, yes. The compress, when it's available, you can get away with 45 millimeters. Wow. That's not a lot of bone at all.
Okay. No, that's very, very small. Rochelle says, I have mine too. I want to be a cool kid. There we go. There we go. All right. So in that first, now here's the other $1 million question. How is the soft tissue treated differently when you have the press fit, or what people commonly refer to as the press fit method.
Yeah, even the compress or the long stem implants. We've learned a lot about the soft tissues over the years, and I would still thin the cutaneous flap, which is the layer right under the skin. There's skin and fat. I would still thin that as thin as possible, maybe to a centimeter,
Okay.
and decrease the relative motion as much as possible, and anchor that skin all the way around to the underlying fascia. And fascia is the muscle covering. It's the white stuff you trim off your tenderloin, but it's stout. It holds a stitch, and you can sew that skin right down to it.
There you go.
The answer, Kosi, is you do everything you can to thin the flap, the
Mhm.
cutaneous flap, and then minimize motion there by suturing it down in a thoughtful manner.
Okay. And then, guys, when all is said and done, and everything is healed, with the OPRA system, you have this nifty little Axor 2 device, and then it connects to your prosthetic leg. But I much prefer this good-looking guy. So here you guys can see Glenn standing up, because obviously in this tiny little screen, we can't appreciate what it looks like in real life. So Glenn, tell us about life after OI and everything that you are doing. You hinted at a couple of things already.
Right. Well, you can also see that, I don't have a very long femur, which is probably the reason why I was not a successful socket user. So, I mean, there's not a lot there. So, and try to get a socket to fit and to be comfortable, it just was never a thing.
Yeah.
But so in my little video, when you watch it, to me, it just feels like I have my life back after OI. This is, to me, the closest I'm ever going to get to having my natural leg back. I have sensations. You have proprioception. You can feel things, but it's just the peace of mind. I go up on a ladder. Like, I have a house. People go up on ladders. With the socket, I've told the story before. Like, my leg fell off. I was up a ladder cleaning the gutters, and my wife caught my leg. And now it's just the frustration factor. But then you're sitting there going, the reality going, how do I get down safely so I don't get hurt?
Mhm.
So now I just have to remember to lock my knee, because my knee has that function. And I go up a ladder, and I can just relax and concentrate on what I'm doing. And I don't have to worry about my leg falling off or any of those things. It just gives you peace of mind. So the best part for me is getting up and getting ready in the morning is I don't have that stress anymore. Because one time I had the pin lock system. When you first learn that system, as you would know, you don't necessarily put in the right spot every day, and you can't get it to go on. And then you're looking at the clock, and I have to be at school. There's kids waiting for me. I can't be late. And then I'm getting more stressed. And there's times where I couldn't get my leg on, and I would have to go to school without my leg that day. And that really that just weighed on me. And now with the OPRA system, I can have my leg on in under 5 seconds now. And the best part is, one, it's on, it's secure, but my foot's in the exact same spot it was the day before. My socket's not digging in the back. It's not digging in the front. None of those problems. When I sit down at my desk, sometimes the grade, I would lose suction. So now, if I was wearing shorts, it wasn't a big deal, but it's a little awkward in front of a class of students to try to get your leg back into your socket. So it has just eliminated all of those things in my life. So I told you, we were talking earlier, that we had snow yesterday. So I worked all day, came home, relaxed a little bit, and then I'm helping my friend out, plowing. He has a commercial plow job. So I plowed all night last night. I didn't get done till 5 a.m. So I was driving home realizing I had my leg on for 23 hours yesterday.
Holy cow.
I never could have done that with the socket.
No.
I never could have sat in a plow truck for 8 hours plowing with the socket. I just would have been comfortable. The liner would have bothered my skin. And I'm not saying that I felt great after 23 straight hours, but I didn't have any pain because of the leg or the attachment or any of that. And I walked right in and went to bed. And it was like things like that just gives you your life back. And you just feel, you feel more normal than I ever did with the socket. And it was frustrating because you go online and you see people that are running 5Ks in their socket and they're doing all this. And I'm like, that's amazing, but that was never me. So, and now I just feel like I have a life. I can live my life. So when I coach football, football up here, and we're not as hot and uncomfortable as you are in Tampa, but we have humidity up here in August, and we're doing 2 days. And with the socket, it's baking my leg. And we would come in after the morning one, and this is gross, but we've talked about it. You take off the liner, and you're pouring the sweat out. I would keep cold wraps in the freezer in the trainer's office and wrap my leg to try to keep the swelling down. It got to the point where, and I would end up getting a sore. I would get a blister. Trying to walk out to the field, it came to the point where I'm like, I don't think I can coach anymore at the socket. And I actually stopped. I'm like, I'm done. And then I had OI and then I came back. So they're like, I'm like, I think I can do it. And I haven't been able to walk to the field since my amputation, and I can walk to the field now. During the season, I was averaging 14,000 steps a day with my leg and feeling good, not having any soreness. Like, those things to me have been just a life changer because of OI. And I'm so thankful that, it was offered to the civilians and I was able to get in there early on. And then I'm very happy with the outcomes. So it's been great. Now, we talked about, the infection. Everyone's worried about the infection, and I was paranoid of the infection, like I'm sure everybody is. And, and I know that the theme is, and we'll get into this more, is just like taking care of and keeping it clean. And in reality, I'm almost 5 years out now. I was like, I had a few infections, minor infections the first year. I've had none since. So I'm going to chalk that up as a win.
And we're going to get in a little more detail of that in just a moment. We have just so many lovely testimonials coming in. I just want to touch upon, Jim is giving basically his beautiful story about Dr. Forsberg and saying thank you to Dr. Forsberg seems very inadequate.
Jim, you're so kind. It's really good to hear from you. I miss all my patients. I miss all of you. And I wish you would come to New York and just, say hi or something. Drop me a line. You don't call, you don't text.
You don't write.
You just ghosted us there, Dr. Forsberg.
What?
Yeah. We should all get together. We should get a big coach bus. We could all come up and you can show us around. It'd be fun.
That would be delightful. I would love that.
And then Emily is asking, does OI work for someone with hip disarticulation? I know regular sockets are difficult for that population.
It has been tried. The challenge is, the hip socket comes out almost at a 45-degree angle. So is it going to be uncomfortable when you sit, or is it going to be uncomfortable when you walk? It's a trade-off.
Yeah.
That's a tough one. And I would say that's still in the experimental phase.
Okay. Donnie's like, I live in Florida and I pour the sweat out of my leg twice a day here as a BK. I was like, when I go running with my amputee runners, we're stopping at least a couple of times to pour out sweat. It's intense. Let's see. Here we go. Mary for quite the win. Sorry, guys, trying to keep up with you guys here. This is quite a few comments. Guys, by the way, if I do miss your question or your comment, I am going to go back after I close the show down, and I will be sure that we get all the questions answered if we're not able to do that tonight. But in the meantime, let's talk a little bit about the skin healing process after stage 2, right? So we talked about those first few weeks where it's just like your physical therapist, woohoo, is teaching you how to move without moving the residual limb. So it's a fun little tango there that we're doing, where we want you up and moving, but we have to teach you a certain way to move so that you don't ruin the beautiful work that was done on that soft tissue part. At what stage, Dr. Forsberg, does the hockey puck come off and the sutures and all the fun begin?
It's if you could show a picture of the fresh post-op, I would love that. So, we do everything we can to stabilize this. This is a great shot right here.
Yeah.
We do everything we can to rotate that flap into position and then sew it down so that it heals over the end of the bone. And you can see where the aperture is coming out, or the abutment's coming out.
Right there.
You see that very thin skin that almost looks blue?
Yep.
And the blue is circular, and that's because it's overlay on the femur. So what you're really seeing is the outline of the femur with a very thin layer of skin over the top.
It's right there.
It's right there. And we thin that flap out. We take all the fat away from that skin, and we get all the way down to the hair follicles. So we're seeing the hair follicles from the inside, and then we're laying that down over the end of the bone.
That's
so, seeing a little bit of blue there, or even some duskiness, is totally normal. And I tell patients that your wound here is going to go through this awkward 7th grade healing phase. There's no cure for the 7th grade. There's no cure for this. It's just got to get through it. And most of these, about 95% of them heal uneventfully. Some of them need a little TLC care and feeding.
Right. And then the after picture will show you the sneak peek of that's the same patient, guys. The after picture. And that is healed so nicely.
Yeah. So to answer your question, Kosi, we watched the aperture site and the watershed area, which is a triangular shaped area just above it, because the blood supply is tenuous in these flaps. So we watch them very carefully for the first couple of weeks. And if they come back and we're taking the sutures out and the aperture looks fine, I tell them get rid of the hockey puck.
There we go. And then There's so many questions I have right now. I'm trying to find the slide deck. Here we go. Shall we take a look at some more work? I love these pictures. These are great pictures.
Yeah, these are great examples, Kosi. And just take a look at the upper left. You can really see the outline of the femur there.
Yep, right there, nice and clear. Yep.
Yep, nice and clear. And there's a little dimple from the suture, in the upper left and the upper side, and in the middle, the top middle picture, the dimples are on the other side. This is what we're shooting for. And I tell the fellows when I'm teaching them how to do this operation and other surgeons, I'm like, we want world-class dimples here. We want that skin just draped nicely over the end of the femur so it can heal. And it's a really fun part of the operation. It takes time.
Yeah.
To rotate that flap into position to get it to sit down just right. And sometimes if we put in a suture that's too tight, it might strangulate part of the flap. We don't hesitate to take that out and put it in nicely so there's plenty of blood supply.
No, these would make
this is what you're shooting for. You asked me earlier, why did I gravitate toward the OPRA? Not just because it's FDA approved, but because it produces a skin penetration site like this, and nice folks love that.
Yeah. Yep. So do you want me to say the not so great outcomes and talk a little bit about that?
Yeah, let's see it. I see a lot of second opinions out there, folks, come from all over, and I will never say no to a second opinion. You want to come and talk about, whatever it is you want to talk about, please do.
Okay. And guys, just so you know, for those of you, I should have probably warned you beforehand, but the picture I'm going to put up now is unfortunately what should not be happening at the stoma site. So some of these pictures are a little graphic. So for those of you who do not want to see this, go ahead and exit out now. And let's go ahead. Let me make sure I've got the right. There. I want to make sure I got the right picture.
There was a question there. Do I do the follow-up, or do I have a plastic surgeon do the follow-up? No, I do all the follow-up. I do all the surgeries. I do all the follow-up.
Yeah.
So these are great examples. We have one long stem in the upper right that's obviously infected with way too much soft tissue, and then we have 3 OPRA implants. And these are patients that I saw in consultation, and almost, with the exception of the upper left, almost no attention was paid to the soft tissues. These are going to be disasters if the soft tissue isn't taken into account. They're going to get infected. The more motion you have at the skin penetration site, the more inflammation and unhappy tissue
right here
is ripe for bacterial growth.
Yeah. And this is where you can see what we call the hypergranulation tissue, guys. And that's basically when you have that friction and shearing force happening, when there's movement there, and if you're wearing a socket, it means you get a blister. If you have OI and you have movement, it means you're going to get this hypergranulation tissue, this drainage going on right here that we see that is no bueno.
Right. And I see, patients all the time in second opinion, and they complain about the drainage. One of my patients has to change his sheets every morning because the aperture, the skin penetration site is just so patulous. And that's terrible. That's not a great quality of life for this gentleman.
Now, obviously there's a commitment to having this done. And I tell folks this all the time. I'm like, it is a year of your life, essentially, between the 2 procedures, the intense rehabilitation that you need to be doing, which we've harped on that several times in the past. And then also the skin maturing and the exit site maturing. And then notice, guys, we use the word aperture and exit site. We have not used the word stoma. And there's a reason for that, because
Google the word stoma and see what comes up on your phone. That's
yes, and there is a distinction. And again, I agree with Dr. Forsberg when he says there's a time and place for each implant. But obviously one of the benefits, in my opinion, of the OPRA system is that it is an exit site, and it's a very aesthetically pleasing exit site. So how long would you say it takes on average for someone to kind of reach that maintenance level with their exit site?
Glenn, how long did it take you?
It's funny, when you think back to things, and I was just thinking about like the whole year you give up, and sometimes it's hard for us to remember those things. And I think because it was so worth it, you kind of gloss over how long it took. But I left the hospital after a day and a half. So I guess I was taking care of it 2 days later. So, and the puck was on there. You had a whole stack of things. And then I guess I think we just rotated them through. I have a hard time remembering. It wasn't much of an issue at the very beginning. All you do is you just take them off. I don't think you even clean it though. You just rotate. There's a whole stack of little gauze things they had on there, and you just rotate them through.
Yeah.
Thanks.
Yeah, I miss those things. They're too expensive to use a whole stack of them anymore. But yeah, you were lucky to get a whole stack.
Oh, good. I was lucky. Look at that. I'll take
it. Look at that. I was lucky.
I lost the cancer, thing, but I got good. I worked out well on the surgery, so I'll take it. It's okay.
Yeah.
Fair enough.
And then.
So it can take a while, Cozy, and every limb is different. We had 51 of these limbs in the clinical trial we just published in transfemorals.
Yes.
Most were short. Most had other difficulties with random pattern flaps, blast injuries, retained shrapnel, heterotopic ossification, things like that.
Mm-hmm.
So I would agree that it takes time. And even though we removed the hockey puck at stage 2, that the skin penetration site will continue to mature for about 6 months.
Yep, that sounds about right.
If it's constantly being perturbed with motion, it's going to take a lot longer, and it may not ever heal. If there's too much soft tissue, too much motion, the skin will delaminate from the end of the bone, and it will never heal back down again without another surgery.
And guys, this is where
it's important to be cool after surgery.
Yeah. No, and guys, this is where you've heard me harp again and again and again and again, the importance of just not only having a qualified surgeon and an experienced surgeon, but looking at that surgeon's team, because it truly does take a village for this procedure to be successful. Between, like Glenn said, when he went in for his first consult, he felt like it was an intervention. The whole village was there at the same time. And a big part of that is keeping you on track. And keeping lots of pairs of eyes looking at the surgical site and making sure that everything is healing correctly. And in the event that something does not go as planned, that there is a plan to address that as well. One thing I wanted to ask, so Glenn, your daily cleaning and maintenance, what does that look like?
It's really pretty straightforward. Now, it's different today than it was the first year. The first year, my skin was a little slow to accepting its new state in life here. And it was a little challenging, and the cleaning process was different then. But daily, I can pretty much cover things just with a daily shower. But there are times where, like, sometimes we go to these conferences and the handicap accessible room isn't so handicap accessible, so I can't use the shower the proper way. Mm-hmm. So all I do is I found these cool little things, more visual aids for you. And these are just little dental gauze that I got off of Amazon, because everyone else just uses, a washcloth. But I know I'm not great at of cleaning the washcloth. It sometimes falls on the floor, and the thought of using the washcloth, I just don't like that idea. So I just use those, and then I just use use ivory soap, and I clean it real nice. I use nice hot water. I do a couple with the soap, a couple with I rinse, and if everything usually looks good, I usually that's it. That's usually all I have to do. And then, sometimes I'll do twice a day. And honestly, some days if I just check it in the morning, and if for some reason I had some discharge overnight, I don't ever have I don't ruin my sheets or anything, but sometimes it'll be a little bit. Now I'm also on blood thinner, so I think maybe my situation is different than others. Mm-hmm. Yeah, and sometimes I'll just use those little gauze in the morning if I took a shower at night, and then I'm good to go for the day. Now I do have a wood shop, and then I'm concerned about the dust and stuff out there. And if I'm wearing shorts or anything like that, I'll come in and I'll clean myself just to make sure I'm not getting a little, who knows? I don't want anything going in there to make my life a little more uncomfortable.
It's common sense. It's common sense hygiene is basically what is needed to keep it clean. Ginny's saying, I've had several soft tissue revisions and don't have the prettiest aperture because of it, but it's still adhered to the bone and has very little movement, just over 3 years now with no infection. Van Gregory said, once again, I'm sorry, Van Gregory, we missed your question earlier. What is the material which fuses to the bone made of? So it's a titanium metal, and that's my Mickey Mouse understanding of it. Dr. Forsberg.
Commercially pure titanium. Bone loves the titanium oxide layer, and that's what Professor Brodemark figured out in his basic science experiments in the 50s, which translated to the dental implants, as Cozy pointed out.
Yeah, G.I. Jane, I'm sorry, it's not duct tape. The answer is not duct tape, but I applaud.
It's not duct tape.
Duct tape, we can use it for pretty much everything, including keeping sockets on during surfing activities, but not for this case, I'm afraid. Guys, let's take a quick break. We have one more giveaway for you. This one is about Glenn's PT story. So, I had to sneak that in there just for a minute. So guys, let me make sure I get the right thing here. Here's what you got to do for me. Click on that QR code and you got to scroll through his story. And I want you to read it later, so save it for later. But tell me, where did Glenn receive his physical therapy? And I'll give you a hint. It was not at Johns Hopkins. He had his surgeries done at Johns Hopkins. But where did he receive his follow-up physical therapy? And then put that into the comment section, and we are going to pick out a winner. All right, let me just scroll through the G.I. Jane. She's having a good old time laughing at me right now. All right, guys. We have a lot of people with hockey pucks sitting around. We need to do just that. That's just an Instagram story waiting to happen right there.
Absolutely.
Yeah. So Glenn, while people are doing that and putting that in the comment section, y'all, I better see a whole bunch of y'all doing that. I need to see y'all doing that, looking at his story and tell me where he had his PT done. Show me some love there. Mary, I can't wait to have you on the show, Mary. You and Carol are my other two. My house. Gee, Jane, you were on fire this evening. You were on fire, but you know why? She's a paratrooper. And so when she heard that Dr. Forsberg is from the Navy, she had to come in and represent. So that's why we're getting a lot from the peanut gallery tonight. So Glenn, you talked about in the first year, you did have a couple of superficial infections. So tell us a little bit about that.
And I can say that, and I don't know how every OI team in the country works, but the way that Hopkins was set up is Dr. Forsberg's physical assistant, his PA was great. If I had, if it was bothering me or whatever, I would just text him, and he was great about. He is still great about getting back.
He's wonderful.
Francis is on the ball with texting, and he would come back and he would say, "Take a picture of it." And I have all these weird pictures of my site because it's bothering me. So I take a picture and I'm concerned about it. So then I would send it off to him, and then and then they would usually say, "Okay, well, we'll call in some antibiotics for you, and then we want you to go get an X-ray just to make sure that nothing has moved inside or anything else." And I'm not sure what else you can see on an X-ray. Dr. Forsberg would have to answer that one for me. And then I think that happened twice or three times in the first year. And then after that, my skin, I think, finally decided that it was okay and that it was now used to this thing sticking out of it. And then since then, I've had no more of those issues. Thankfully, I'm very happy about that.
And guys, I'd love to hear from some of our other OPRA ambassadors in the audience this evening. If you guys don't mind putting down, first of all, if your cleaning regimen is different, because I know everybody probably has their own twist that they put on it. So put that into the comment section. And have you had any issues with superficial infections or deep infections since you had your OPRA system put in? So we like to be, finally, we're getting some real answers. Y'all are just hecklers at this point.
I see some in there.
At the PTist office, really, Grasshopper? Is that what you're saying? This called a PTist office? All right. So all right, guys, I'm going to give you guys 30 more seconds to put the correct answer in. And then my gal Jamie's going to pick a winner from the background. So moving on, I lost my train of thought because of G.I. Jane's comments there. See, that's what happens when you guys are trying to distract me. It actually works. So Dr. Forsberg, with regards to infection, that's always a very popular question. What is the rate of infection, superficial versus deep? What is it that you see in your work?
Well, we just published a paper. This came out of Walter Reed. We wrote the study. This was myself, Kyle Potter, Jason Souza, Ashley Anderson, and we had 51 limbs. And we followed those 51 limbs for 2 years. And we collected absolutely everything we could about these patients. They were all military beneficiaries. They had free access to care. And 22 of them developed an infection out of 51. So 29% of those were just superficial infections.
Okay. So meaning they were cleared up with a quick oral antibiotic.
Yep. We usually give double strength Bactrim or Duracef, which is twice daily, very well tolerated, and they cleared up. 7 were deep infections, and only 1 of them involved the bone. So in 51 limbs, those are pretty good odds. And in fact, the risk of infection in our military patients, which we theorized might be higher than the initial Swedish cohort, was actually lower. So the vast majority of patients in that study never had an infection. And that surprised everybody. It surprised, it surprised us for sure, but it surprised viewers. And I'm proud to say this is now out, and check it out. It's in Clinical Orthopedics and related research. And I'll tell you this, not all journals are the same. Just because it's out there in the literature doesn't mean it's gospel. It also doesn't mean it was a good study. Also doesn't mean you can trust the study. But I'll tell you what, if anything's published in clinical orthopedics and related research, you can trust it. You can take that information to the bank.
Absolutely.
Now, the upper extremity study, we did a transhumeral study.
Yes.
Guess how many infections we had in 2 years? Glenn, what do you think? Guess.
I'm going to say 0.
0 infections in 2 years.
Look at that.
You're kidding. 0?
Not kidding.
That's big talk.
I didn't.
That's like a drop mic.
The only reason I said it is because we observed it. That's the only reason you can say it.
Wow.
Yeah.
That is impressive.
And again, emphasizes the importance of the soft tissue. There's less soft tissue in the upper extremity. It's cleaner up there. We have an easier time managing the soft tissues.
Yeah.
We all of us learned from Jason Souza, who you all know, I'm sure.
Oh yeah, he's been on the show.
Plastic surgeon. Yeah.
Wow. So, and again, this is something that, when Dr. Shu was on the show a few months back, that unfortunately infections do happen. So in the event that one does happen, being with a surgeon that knows how to handle it, because unfortunately we do hear of some stories where the patient has an infection, they're in a geographic location that's far away from where they originally had the surgery, and they don't have that support to have it handled properly. So guys, again, if this is something you're considering having done, please, 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 please research your team very, very carefully, very, very carefully. Let's see. Adam is saying, do you need a fragrance-free soap when cleaning? I would say yes, fragrance-free. And just me and my recommendations, and I'd love to hear Dr. Forsberg's take on this. When I used to work wound care, and even when I talk with my patients, I actually don't encourage antibacterial unless there's a previous history or a really indicated need for it. But like what Glenn does, he uses ivory soap, just something that just clean the debris out and let the natural body flora do its thing. Dr. Forsberg, do you have any preference in that regard? Antibacterial?
None whatsoever. I think you're exactly right. Just some mild soap and water. There are a couple of things out on the market. I mean, you can use peroxide if you want to sparingly. There's Vosh that if you just want to spend some money on something that's like more pH balanced and you don't like mild soap and water, you can buy some Vosh. But yeah, almost anything that doesn't disrupt that interface will be just fine.
Yep. And then let's see.
Benny Cortez said USMC, Semper Fi.
Yes, he is my Marine guy. He is here every week. Jill is saying Dr. Potter was my surgeon. He's awesome. Just a shout out. Let's see. Jim is saying 2 years post OI and 0 infections. Knock on wood. Rochelle is saying only 1 superficial infection. Dermacleanse like Jeannie and when not showering. And then Mary says similar to Glenn, 3.5 years out and no infections. Ginny says I use Dermacleanse if I'm not in the shower, just soap and water in the shower, and I'll use HiPACleanse if I've been swimming or somewhere not so clean. So again, there you go, guys.
There you go.
At this point, so we talked about those studies, which is just kind of incredible. I printed it out today, so I'm going to be reading it with a fine-tooth comb a little bit later on. And in the meantime, we have some winners, guys. I'm looking at my phone, not because I'm being rude, but because they're trying to text me who the winners are. So one of our winners this evening is Emily. And they are trying to figure out from a handle who this next winner is because they chose it from the YouTube. So Emily D, congratulations. And guys, let me just put down, I keep forgetting to do this. This is my email address, guys. For those of you who are new to the show, this show is meant for you in the amputee community, clinicians, caregivers, amputees themselves, and their family members. So that is my email address. That is one of the many ways to get in touch with me. Emily, you are the winner this evening. So please send me your address so I don't have to go chasing you down, and we can send you your prize. You're going to be having a really nice Integrum swag bag. And okay, come on, Jamie, give me a name, girl. Give me a name. We're trying to get that second winner to you guys. Let's see. Carol says, I use wound wash and gauze for a few superficial infections. And there we go. We have Jennifer Denninger as our next winner. So Jennifer, this sounds familiar. Is this one of your students?
This is not a student. This is a coworker, Jennifer Denninger. So
there we go. So you're going to be able to chase her down for me if she doesn't send me an email address. So Jennifer,
for you.
Jennifer, thank you for watching. Please send me your address so that we can send you your swag bag as well. So guys, a wonderful, wonderful show.
I want to know what Carol Davis uses. Which wound wash does Carol Davis use?
Oh yeah. Carol, curious minds want to know.
So as we're waiting for Carol to put her answer in, you're saying if anybody's interested in OI, if you go out to Integrum, you can ask to be put in contact with one of the ambassadors. And we love to talk to you. Like we'll tell you, we'll talk to you on the phone, we'll text with you, and then we'll be with you if you want to go through this journey. You know, if there's any time you have questions or stuff, we're there. I mean, this is one of the great things about. And then when I went through this, when Integrum offered, I'm like, I'll do anything I can to help promote this because I've had such great success with it, and I would love to share my story. And there's a few people over the years that have, that Integrum has put us in contact with, and all of us that you see our names are popping up on here. We'll gladly, spend the time with you, let you know what's going on, and help you out if you have questions or you have concerns. And we all get those moments. Now, you see, Susan and I have been great friends from the beginning of this, and this is before we had ambassadors. And Susan and I both went through with Dr. Forsberg and kind of, met each other through Kosi's show. So we were like, buddies going through it together, texting each other all the time, going, "Hey, are you having this?" And then she would take better notes with Dr. Forsberg than I would. And I would be, "Did he say this to you?" And be like, yes. But that model was really helpful because no one knew anything when we first went through. Now it's way more information out now, and it's way more helpful now. But Susan has been, Susan and I were, we kind of relied on each other going back and forth. And, Susan's the queen of going to Hopkins every week and, every month. And so she got a lot of those tips and tricks down there.
Mm-hmm. And guys,
Glenn, there's a special place in heaven for you.
Oh, thanks.
Truly.
For both of you. And then folks, if you haven't heard Susan's story, she has been on my show and it's incredible. She is how I learned about Dr. Forsberg, because she could not stop singing his praises and how he literally gave her life back. So that's a beautiful story right there. And I'm just seeing names of other people that I can't wait to have on this show to tell their stories as well. And truly, guys, Integrum is an ambassador. I don't speak highly of OPRA because they're my sponsors. I asked them to be sponsors because I really loved the work that they were doing. And I saw what an impact it made on many of you in the viewers. So with that being said, guys, we're gonna close this show on this note because it's just been a really amazing, wonderful show, and we covered a lot of information in this time. So I do want to say again a huge thank you to Dr. Forsberg and to Glenn for taking time from their lives to be with us this evening, and sharing your wonderful work and expertise and your experience, Glenn. And Dr. Forsberg with us. So thank you.
Well, Coach, before we log off, I want to take from all of us in the community, thank you. You've been a great advocate for all of us.
Hear, hear.
For here, and for me particularly with my OI journey. If it wasn't for you and helping me out with Kurt, I don't think I ever would have made it down with Dr. Forsberg. I think eventually I would have driven down there and knocked on the door and said, "Somebody let me in." But you just made that process so much smoother. And thank you every week of putting this show together. And what you've done to us at the beginning, when you don't know anything, you were that one little bright spot where you're like, I can ask somebody that I didn't learn in PT. And that's so helpful. So never stop what you're doing. It's greatly appreciated.
Thank you.
Truly a privilege, Kosi. Thank you.
Thank you, guys. And Integrum, thank you so much for your continued support. Memorial Sloan Kettering Cancer Center, thank you again for loaning me Dr. Forsberg. He is a treasure, and I know that you will treat him well. All right, guys. As always, thank you for letting me be a part of your lives this evening. I will be seeing you guys next week. Same bat time, same bat channel.